Welcome to Variations 4, the Gastrointestinal Accessory Organs Unit. We'll be covering questions 21 to 24 in this video. 21, the overall etiology and management of liver cancer. Looking at map 17, there's not a whole lot to say here. It's not a good outlook. By the time you detect liver cancer, there's a huge chance of metastases due to the high blood flow through the liver. And survival rates statistics are not great for liver cancer. Of course, your treatment approaches are fairly palliative in nature, but it might be some form of surgery, chemo, and radiation. Of course, as they go through, depending on how long the patient lives for, they could mimic the signs of cirrhosis, severe cirrhosis, as the cancer spreads and the liver functioning declines. All right, the next question, question 22, outline the pathophysiology and treatment of acute pancreatitis. Provide a rationale for all the points. So there's a couple of key points I want to go through with acute pancreatitis. First of all, with pancreatitis, you have that beta cell damage potentially, and so you've got not able to manage your blood sugars well, increasing hyperglycemia, maybe on sliding scale insulin. Now, we're talking about a patient who may have no background of diabetes up until this point. This is strictly related to the pancreatitis. You might have them on sliding scale insulin. Inflammation can have a tendency to spread. So even though it's the pancreas that's inflamed, that can spread to inflame the diaphragm. And if that's the case, this patient's going to have painful, shallow breathing and be at risk for atelectasis and pneumonia. Then there's the pancreas itself. The pancreas is releasing enzymes that are actually somewhat digesting itself. It's eating away at itself. And this is a big part of the problem that causes the pain, a lot of pain, inflammation that we talked about, and cell damage that we talked about here. So very painful, especially with eating when these enzymes are released. You might have obstruction of the bile duct because of the inflammation. They could end up with jaundice as well. Lots of nausea and vomiting. With the inflammation comes vasodilation, as you know, and so you could have fluids now shifting into the peritoneum, causing the blood pressure to drop and the abdominal girth to grow. Fever. The shock can lead to decreased bowel activity and ileus risk. I saw a patient once with a severe pancreatitis and had almost all of these things. It wasn't outrageous to say that the patient was presenting with most of these things. In fairly bad shape. So if you look at the head-to-toe diagram here, then given what I've just said, these things, hopefully these points start to make sense. Again, you're decreasing fat if the bile ducts are blocked from this whole thing. Pancreolipase might be given because you might want help digesting intake without relying on the pancreatic enzymes and taking a load off there. NG suction, the patient I was telling you about had that because of the nausea and vomiting associated with the pancreatitis. Drop in blood pressure, they had that too. They might need albumin to try and keep fluids in the vessels, as we talked about. This guy was on TPN because we didn't want to aggravate because TPN, don't forget, bypasses the digestive tract, and so it's already it's fluid, so you don't need to rely on digestive enzymes, so the pancreas doesn't need to work. Of course, though, the problem with TPN, but it's unavoidable, is that it's got glucose in it, and so you're still worrying about your blood sugars. I'm assuming you'll read through these, and as I'm seeing, see that these make fairly, they make sense. You're always monitoring lights with every patient. You could have losses from vomiting or diarrhea or poor nutritional intake. One thing I want to talk about here is the ERCP, stands for endoscopic retrograde cholangiopancreatic topography. Wow, try and say that 5 times fast. We just call it an ERCP. Basically what it means is you're sending a camera all the way down through the esophagus, through the stomach, and into where you can see things like the spleen, the pancreas. You can visualize these organs directly. You can take samples of these organs directly. Nursing considerations before this test: patient needs to be NPO, and when they come back, you want to make sure that they're alert and oriented, their vital signs are all right after the test, and that their gag reflex has returned before they start sipping fluids or eating food, because they have to numb the back of the throat when they give the ERCP. So you want to make sure that they have a gag reflex when they come back before they eat. And you can do that by using a sterile tongue blade, asking them to go ah, and putting this tongue blade towards the back of their throat. And at some point, they will gag, and the gag reflex has returned. Okay, so 23, what are the implications of the patient when the pancreas is removed? Well, like for cancer, for example, well, I mean, if you think about what we just talked about with blood sugars, you're basically turning a person into a serious insulin-dependent diabetic. They're going to need lots of pancreatic enzymes now. So that's number one. Number two, they're going to need lots of pancreatic enzymes by mouth to digest any meal, because now they don't have the pancreas to do that. And you're going to want to decrease fat, because they're not going to be able to break down fat as easily. So those 3 things would be the big things. Of those, probably the insulin-dependent diabetes would be the biggest life-changing, potentially the biggest life-changing thing for them. Final questions asking us to talk about cholethiasis, cholecystitis, and the difference between laparoscopic and open cholecystectomy. Can one live without a gallbladder? Yes, one can live without a gallbladder, absolutely. What happens, instead of the bile going into the gallbladder for storage, which then later on it's emptied into the intestine as needed, now the bile goes directly from the liver into the intestine, and the body will learn to adapt early on. So diet has to be modified, obviously, a lower fat diet, but I mean, people live on and live pretty normal lives with that. Let's answer some of these problems, some of these things here. If you look at map 20 at the bottom, let's go into a little more detail here. So map 20 at the bottom here. Okay, cholethiasis is just gallstones, straight up. It's a combination of these elements here that can cause gallstones, but that's what they are. Cholecystitis is inflammation of the gallbladder. Now, sometimes we don't spend too much time worrying about getting rid of the stones. Sometimes they'll just take you see lots of people who have a cholecystectomy where they'll just go ahead and take the gallbladder right out. So what's the difference between a laparoscopic and an open? Well, obviously with an open, they've used a scalpel to literally open up the abdomen to take out the gallbladder. And with laparoscopic surgery, they're using tools to go in. Let's take a look at laparoscopic surgery just real quick here. So here you're seeing an example of laparoscopic surgery. Now in this example, they're using 4 devices. Many times you'll see 3 being used. Let me just try and get a zoom on that again. So you might have one of these or 2 of these, maybe a camera, and these guys are actually, surgeons are looking up at the television screen here at the camera as they work, and the other arms might be, rods here might be things that can grab, things that can lice, things that can, burn away things, take samples, cut away things. They can do quite a few. I mean, I've seen people have kidneys removed this way. It's amazing what they can do with these tiny puncture sites. the type of surgeries they can do. Sometimes they'll try and do a surgery with laparoscopic surgery like this, and it won't work out. So we'll have to take these out and then use a scalpel and go to open. So sometimes you see patients come back with laparoscopic wounds and an open incision, a surgical incision, because they had to abandon this and go for the other one. But they usually like to try this way because it's minimally invasive and the healing is much faster, as you can imagine. When they come back, they just have like a steri strip and maybe a tegaderm over this area, these 3 or 4 areas. Again, sometimes it's only 3, sometimes it's 4. And they can do a whole variety of surgeries using the laparoscopic devices. And the final part of that question was, can someone live without a gallbladder? And yes, they can, and they have to adjust their diet, and but they totally can, and it flows directly into the fat bile. Bile flows directly into the small intestine now via the common bile duct, but they can absolutely live without it. And so the last part, last question here, I believe, asks you to look at the Seawall Form, the Seawall cases. I'm going to get you to do those on your own, and we will review those cases when we meet, or I'll post something up later on with the answers or whatever. It's an interesting discussion to have. But in a nutshell, you've got this Seawall Form, which you can look at. And I'm going to open up the cases for you here so you can see those too. And you just, the Seawall Form is basically for alcohol withdrawal. It's to monitor alcohol withdrawal. And what it is it's got various sections that you fill out based on your patient presentation. So you got to remember that with alcohol withdrawal, it usually kicks in within about 1 to 2 days, 24 to 48 hours since the patient last had their needed dose of alcohol, if that makes sense. So if they drank the 8 beer they usually drink last night, you got, a couple days from that point before the withdrawal really sets in. And this helps capture that because, as we talked about earlier, alcohol strips the bodies of vitamins and nutrients. And some of these symptoms we see here are because of that. And then the second part to remember is that alcohol is also a sedative. And so, and you know that when you take someone off of a sedative like Ativan too quickly without weaning, you get withdrawal responses like an over-stimulated nervous system. And that is also what we see within this as you read through this. And so it's not a surprise to see that when you get certain scores on this this form, that the treatment is lorazepam or Ativan as a sedative, and the doc will decide what that is. So if you look at the cases, let's take a look at it now. I want to encourage you to try these cases on your own. And then we can talk about it at a later time. So you've got these mini cases here. And if you look at these, then what you want to do is read through each one. There's case A, case B, case C. Each are separate patients. Read through them and give them a score on that CIWA record. So patient A, B, and C, just treat them separately, even though they're you only use one of these sheets for one patient, but we're only here for a minute doing this. So just do 3 separate columns for one for each case, and try and determine what score they get, and then try to determine whether the doc needs to prescribe, whether you'd be giving diazepam or lorazepam based on the score. So for example, if the doc circles this one, the middle one, then it means if they score below 10, they get nothing. If they score 10 to 19, they get whichever one he's chosen to prescribe. And then you reassess it in an hour, every hour, and do what you need to do until the score is less than 10. On the other hand, if the score is greater than 20, you give this amount if he's chosen diazepam, or this amount if she's chosen lorazepam, and repeat again until the score is below 20. So let you go ahead and do those. I'm going to tell you right off the top, I've done this for years, this exercise for years with students, and no one ever gets very few people ever get the exact same score. This really ends up being a ballpark figure because there is a lot of observer variance and even patient reporting variance in terms of measuring this, it's a ballpark. And that's why these are kind of ballpark numbers. So for example, if I tried to do the score and I got a 9, but the patient kind of seemed agitated and my gut feeling was telling me that he needed the 10 milligrams of diazepam, I'd probably rescore again and make sure it shouldn't be a 10, so I can give him the med that he needs. All right, well, that concludes this unit on GI accessory organs.